Good afternoon, everyone. I am Dr. Samir Dalvie, and it is my pleasure to moderate this particular session. Another capsule from the ASSI ASSICON global webinar, where we get together the global societies to give you academic information. Today's topic is complications, and the format is a bit different than what we've had in the past. I will tell you this when we kick off. I would like to first introduce our Indian faculty for this before we go to the foreign faculty. I have my co-moderator, Dr. Satyen Mehta and Dr. Neeraj Gupta. And as faculties, I think everybody's known, so I don't need to introduce them. The faculties, we have Dr. Arvind Kulkarni, again from Mumbai. We have Dr. Umesh Srikanta, very bright neurosurgeon from Bangalore. We have Rohit Amratanand, bright orthopedic surgeons from down south. We all know him so well. And we have Neeraj. I hope I've not left anyone out. We have Raghuprasad Verma from Mumbai, of course. And these are the bright young guys who are going to help us come to a conclusion on this topic. Our foreign faculties are Geblu, Manabu Ito, Jason Cheung, and DK Chin, but I hand over to Dr. Abhay Nene, who is the chairperson so he's not here for ASSI or BSS, though he's a member of everything. He is here because he's the big boss. He's the chairperson of the AO Asia Pacific, with whom we are collaborating this, and I hand over to Dr. Abhay Nene to introduce the foreign faculty. Abhay?
Thank you so much, Dr. Samir Dalvie, for putting this all together. As you know, the AO Spine is the only true international spine academic association which stretches from South America down to Japan. And we truly represent the globe. And it's an inclusive society which loves to collaborate with all, hectic academic societies of the world. And ASSI is clearly one of the largest and most academically busy societies. So we are happy to be on this platform with the ASSI. We would like to deeply thank the 4 senior members of the AO Asia Pacific. Dr. Manabu Ito, the past chair of the AO Asia Pacific, and everyone knows him as the brightest star from Japan because he's done some stellar research work and he's a great leader. And thank you, Manabu, for taking your time. Dr. DK Chin, the past education officer for the AO Asia Pacific. He's a neurosurgeon from Korea. Again, an extremely bright doctor who actually hand cultivated the last cadaveric course in Bangkok, which was such a big hit. Dr. Gabriel Lu, he's not a stranger to Indians. I know at least half a dozen guys who've done fellowship with Gabriel in the NUH at Singapore. And thank you, Gabriel, for taking the time and for helping our fellows work with you. And of course, Dr. Jason Cheung, who leads the academic activities in Hong Kong. He probably is the most published author from Hong Kong in this current generation. So thank you, you 4 guys, because we couldn't have hoped for a better representation of the AO Spine Asia Pacific. And thank you, ASSI. Thank you, Dr. Badani. Thank you, Dr. Vishal Kundani. And thank you, Dr. S.K. Srivastav, for having us on your session. Samir, handing over back to you.
Yeah, in fact, I hand it back to the organizer. I hand it over to Dr. Ketan Badani to give the welcome address.
Hello, good afternoon, everybody. It's a pleasure to, on behalf of the BSS, to invite you and have you as faculty on this excellent program. As you all know, and as Dr. Vishal Kundani described, this event is actually the ASSICON before the actual ASSICON. The physical ASSICON is going to be in January, and we are having an ASSICON, and it is our privilege to have you here collaborate with us. And on a very interesting topic on complications which we face in and out every day. So on behalf of Bombay Spine Society, I welcome all of you, all our Indian faculties and all the faculties from AO Spine Asia Pacific to join the meeting and have very exciting deliberations, interesting talk. And I hand over back to Samir, Dr. Samir Dalvie.
Dr. Srivastav, would you like to say a few words to us?
Sure. So thank you, Dr. Samir. A very good afternoon to all of you and very good evening to all my foreign colleagues. Actually, this outreach program is one of the very bright program which has been curated very nicely by the scientific committee. And you know that BSS, that is Bombay Spine Society, is going to host ASSICon 2024. And these all global outreach program are actually the pre-conference academic session. And today's program is very, very important. That is complication in spine surgery. We know this is such an important thing that if suppose one faces this problem, how to tackle it. And unless you know all these, you will not be able to prevent it. So this is a very important session. And I thank you all the faculties from ASSI, BSS, and our own colleague, that is Asia, AO Asia Pacific. Thank you very much and all the best for academic session. Thanks a lot. I hand over the proceeding to Dr. Samir.
So we are now starting with the academics. As I said, this is we wanted to do this slightly differently rather than have lectures which people will zone out of. I thought let's have it more as a case discussion and a question and answer session to get out the same relevant information, but in a more exciting fashion. And anyway, I feel that our work is all about that individual case and that individual patient. It is never about a series or it is never about statistics, because each patient wants the result from us. And each patient who has a complication wants the answer or the treatment for that complication. So I think case discussions is the best way to impart knowledge, really, which will help us in our practice. So without much further ado, I start the first topic. And my request to those who are not on the panel, because each of us is on two panels, those who are not on the panel, to keep your camera and mic off. And so right now for the first panel, which is Dural Injury and CSF leak, the case will be presented by Dr. Umesh Srikanta. Who can start sharing his screen, please? And the panelists are Dr. Jason, DK, Rohit, and Raghuprasad. Dural injury and CSF leak, especially for orthopedic surgeons who do spine, the dura and the CSF is one scary boundary to cross. I think neurosurgeons may be very, very comfortable with looking at CSF, but orthopedic surgeons, it comes at the edge of their expertise. And very often we do tend to have to deal with this, and we really need to know how to do that. One can't do spine surgery unless we can manage these. So, Dr. Umesh, please take over from here.
Yeah, thank you. Thank you so much, Dr. Samir. At the outset, it's a great honor to be part of this elite panel, and it's a wonderful idea on behalf of ASSI as well as AO Spine to come together before the biggest event of ASSICon 2024 and do a global outreach program like this. I tend to disagree because there is a saying in neurosurgery, I think other neurosurgeons in the panel might agree, that neurosurgeons are more afraid of water than blood. So when it's not intended to see, CSF leaks cause as much scare for neurosurgeons as much as for any spine surgeon for that matter. So I'm here, with this particular case that actually went on over for nearly around 2.5 years. At multiple episodes, we had encounter with this particular patient. So let's go into the case. This is a 48-year-old male. He has a known diabetic on treatment. It was pretty much under control. So I'll come to the clinical history, but I'm not going to cover this section into the discussion. So he had a C4 corpectomy and decompression. We ourselves did it around 5 months before the actual story starts. And, these are the pre-operative and post-operative images. Pre-operatively, he had an OPLL.
But Umesh, can you play your presentation? It's not playing. Just do a play and then go ahead.
It is, okay. No, it is actually full screen.
Yeah, do a play. No, but do play. Play it. Press the view screen. Slide view.
It is on. It is on. Actually, I am now. Is it viewing?
Okay. So the thing is that you are showing us a different screen and you are seeing a different screen. Anyway, go ahead.
Okay. So otherwise, what we can do, just a minute. I'll stop share. I shared the PowerPoint presentation. So what I'll share my desktop.
Yeah.
And, that is going to solve the issue. Is it clear now?
Perfect. Yeah. Yes. That's what we are. Thank you.
Okay. Yeah. So this is the story that started several, 5 months before, we had done a C4 corpectomy for an OPLL. He had come with myelopathy. I'll come to the clinical details, and this is the pre-op, post-op. This is not a part of this particular discussion. Basically, what he presented to us was bilateral upper limb and lower limb stiffness of 2 years, which was progressive. He had a trivial fall at home 1 month before. And, after that, he became wheelchair bound since the fall, and he came back to us with an urgency of micturition. He actually improved significantly in his upper limbs after the cervical surgery, but his lower limb symptoms continued. And this is examination at the time when we had a dorsal spine, evaluation. We knew the complete pathology in the beginning, but we decided to stage the surgery. Initially, surgery was done only for the cervical spine. So his bilateral tone was great to Ashworth. Sensation was reduced below D12 level. He has brisk reflexes, and this is the power. He had significantly decreased power more on the right side than on the left side. And these are multiple levels. So this is a post-operative. He's after the cervical spine. So he has a OLF. He comes from a fluorotic belt near our city here. And, this is an OLF at D1, D2 level. Again, this was tackled without any issues. So lower down, he had multi-level OLFs and, ossified ligamentum flavum. So D7, D8, and these are the axial sections at D8, D9. And this is at D9, 10 and D10 level. So obviously these two are the most significant, most stenotic, severe levels. And we decided to do D1, D2 from the left side, as well as D7 to D1 that was tackled with MIS, and D7 to D11 laminectomy and excision of the OLF. So during the surgery, this was what happened. In OLF, we know that it is quite thick. It is adherent to the dura. So this is a quick video. This is just a small half-a-minute video where, we are excising the OLF. We have done the laminectomy. This is the island of the OLF that has been left behind. We are trying to identify the lateral edges and trying to lift off the OLF from its underlying dural attachment. Obviously, it is very stuck. So, that is the arachnoid that is already seen there. So there is virtually the dura is deficient. It is completely stuck. It is completely calcified. So this is at this stage, when we took it out, so there was we try to keep usually in these cases the arachnoid intact, but unfortunately in this case, the arachnoid got torn and, this is what was seen. So once we did that, so there was a CSF gush. So now I think these are the.
So I'd
things.
I'd like to just interrupt at this point, and I'd like to ask Dr. DK. The OLF, is it very common in your part of the world? Ossification of ligamentum flavum?
Yes, very many patients in Korea
With the OLF. So it's a very common problem for you.
Yes.
Now we have seen how Dr. Umesh has done the surgery very clearly. He has made sort of like a laminoplasty. He has made troughs on either side, and he has tried to lift off island of the whole. So how would you approach this? It is definitely well known that the OLF mass is adherent to the dura. Yes. Sometimes it is part of the dura. So what is your strategy, a prevention strategy? Like, how do you approach this surgically?
So there are I experienced many patients. There is a OLF is adherent to the dura. So in the most severe portion, I first decompress the upward and downward, and then so there is a epidural space, and then I dissect from there, and then if there is so as we can see in the video, I make some small portion, most severe portion. I make some island, and then I remove the OLF, the portion. But during this, there may be most patients it removed well, but in some patients it is so adherent to dura, so it is very difficult and maybe resulted in the dura laceration.
Okay, Jason, are you there?
Yeah, thanks.
Hi,
actually, yeah.
What would be your strategy? Do you encounter a lot of these OLFs?
Yeah, so actually, no, we see a lot of these as well. But I think even in initial pre-op MRI, there's already concerns. If you look at the double ossification sign, it's a pretty likely case of dural ossification. So in these cases, actually, preoperatively, I'm an orthopedically trained surgeon, not like DK. So I would always interact with the neurosurgeon pre-op, and kind of have a discussion with family as well, whether we're going to really try to remove that entire island. If we're doing this ourselves, as well as no neurosurgeon support for such a big patch repair, we generally would talk to the patient about leaving that island intact and trying not to actually excise it. Because if you excise it, there's going to be a big defect. You're going to need a patch repair, someone who's experienced in doing it, which as an orthopedically trained surgeon, we're not. But for tackling this, similarly, I would find a virgin zone that has no OLF and do a full laminectomy, actually make gutters on the lateral side, plan for instrumentation, and use a diamond burr to burr that island as thin as possible and just leave it on the dura without doing anything to remove it. But of course, with someone like DK around to help you do a patch repair, then definitely that would be a good option to remove that entire segment.
Raghu, do you have access to, or have you used the so-called ultrasonic cutting device?
But I think the device is to make the gutters. It helped you in where Umesh got the central OLFs at no fitted with the ultrasonic. There are times that I've actually left. I just said I would have left pieces where unhappy over the fact that I haven't done but it's probably saved me a CSF issue. I have access and I should take the guts laterally, not so much.
Rohit, you have anything to add to these last 4 points about how they would do this prevention strategy?
I think I agree with Jason. I'd probably have studied I'd have done a CT also along to assess what Dr. Muthukumar has described, with dural ossification. And if there is very severe dural ossification, I do what's already been described, like the floating technique. So I plan that pre-operative. I mean, if I'm planning a floating, then I would like to thin down with a diamond burr or with an ultrasonic burr. I thin down that segment, and then after that do the detachment, as you said, the laminoplasty thing. So my addition would be do a CT, assess all the dural ossification signs, and then pre-operatively plan on doing the floating laminectomy technique. And I do agree that I think as far as possible, we should try to leave that dural defects alone, because then they become chronic, and then handling that becomes, another operation. So floating technique is the way I do it.
Right. So now let's go back to Umesh. Umesh, we are back to you now.
Yes. So unfortunately, this is what has happened in this particular case. So basically, we know that there is a large dural defect. The arachnoid is intact over a large area, and there is only the small arachnoid defect at one hole. So what is your strategy? So if we want to go back to Dr. Jason, what would be your strategy, Dr. Jason? So dural substitutes, what kind of dural substitutes would you use in this particular case? Naturally, we have to use some kind of an adjunct in this particular case.
In all my cases where I worked in neurosurgeons, always using a fascial, taking a piece of the fascia and repairing it directly. It seems like it's pretty useful and pretty effective. But I defer to DK, probably is better option to explain this.
Yes, please, Dr. DK.
So in that case, so we can use the synthetic dura, but I prefer the muscle and fascia. So in the backside, on the back muscle, I cut the muscle and fascia, and I repair the dura defect if the dura defect is large. But the important thing is there is a dura defect. This is inside. The fascia should be inside the dura. And then suture is, I think it is more important.
It's more of an inlay graft, you're telling.
Yes.
Is it more of an inlay graft than an overlay graft? Is that correct?
Inside, yes.
Yes. So, but usually in these cases, we see that the edges have gone under the bony defect. It's more laterally located. You may not be able to take a stitch on the edge of the dura at some places because the OLF extends quite laterally. and we have drilled quite laterally in these particular cases. So, and the defect sometimes is under the bone edge. So how do we take care of that? It's more deeper down.
So as for me, so if we do the laminectomy and there is no barrier, I think it is important. It is not good. But in the lateral portion, if there is a dural defect, and then there is some remained bony spur or OPLL or some bony structure, I think it is good for the CSF protection. So in that case, I do not remove, if there is a CSF leak in the lateral side, I do not remove the bony structure. So it can do a barrier for the CSF leakage.
Okay, so you mean to say that there is a, if the defect is under the bone, you don't try to expose that. Expose that edge of the dura to take a suture there. Is that right?
Yes.
So in that case, how do you layer your graft? How do you layer the graft? Is it just at the edge of the bone? Because we know that these grafts, whatever dural substitutes we use, even fascia for that matter, there will always be a gap left behind between the bone and the edge of the graft where CSF can still seep through. It is never going to cover the entire dural defect that we have unfortunately created. So how do we tackle that in that particular case?
So in that case, the direct repair is not possible. I remain it in that situation. Then in the post-operatively, I do bed rest, and in some case, I insert the intradural catheter.
Yes. So we will come to the post-operative management, but this is just for an intraoperative management. I'll show you what we did also. But usually in some cases...
Does anybody have experience with these Durafoam patches? The commercially available, this Durafoam patch? Does anybody use them? Duragen and Durafoam. These are two synthetic. They look like gel foams actually, but they are patches.
We've used Duragen. That was during my fellowship time with neurosurgeons to do when we had Chiari malformations to do the duroplasty. Currently, we're using fibrin glue. Umesh was talking about how you tackle when it goes under the bone. So we might use fascia, anchor it with sutures, maybe a 6-0 proline, and then over the part which goes under the bone, we'd use fibrin glue.
Okay. So I have used these Duragen patches quite extensively, even for big island defects. And it seems to work well. But of course, I use other measures as well, like post-operative measures, which we'll come to. But rather than use sort of facial patches or tightly suture anything, because I have a strong belief that if you try to suture too much, it is the small valve which causes a leak rather than the big defect, which actually doesn't cause a leak. So I would just layer, I tend to layer Duragen patches, and I put a little fat on that to keep it down, and then maybe use the glue. But I don't, especially smaller defects, tiny defects, to suture them, would sometimes just leave a flap, which actually causes a worse problem. That's my philosophy for these. But anyway.
Yes. So basically, and what is the role of blood patch? So Dr. Raghu, can you just answer intraoperatively, we have a defect that we are not able to close completely. Is there a role for a blood patch to be applied? For example, can it be a substitute for a fibrin glue? Is that what I'm asking?
So I haven't had personal experience for sure, because normally in these ones I would actually have a neurosurgeon around to help me through this, but I haven't had personal experience for sure. I presume the others will have. One small point I had to make was the more lateral it gets, I thought even if there is a gap in between the bone to the dural defect, the chance of being able to pack with gel foams and probably put a glue on top might save you more than the central ones. So my difficult ones have been the central ones, not so much the lateral ones, actually, in my experience. But blood patch, I have had no personal experience to comment on.
Okay, so I think we'll go quickly ahead. So usually,
I still want to know, Umesh, I want to know the opinion of the panel on fibrin glue, TISIL, because people seem to think again TISIL is a magic. But I think there are a lot of issues with TISIL. I mean, for starters, you cannot actually use it in an open dura. And I think this message should be very clear to the orthopedic surgeons who are listening. I think many orthopedic surgeons may feel that there is a dural defect and they can pour TISIL on it. But DK, am I right that you cannot
yes.
use
We can ask
glue?
Dr. DK, yeah.
Yeah, DK. That
what is your
do you use
indication?
TCL? How do you use? What's the technique of using the TCL fibrin glue? Do you use it? The TCL fibrin glue?
I personally use the fibrin glue in some case, but in my personal experience, it does not work. If there is a dura defect, because the inside the dura there is a pressure. So as for me, I cannot remember the commercial name. There is a glue with gel foam. This is I insert this glue inside the dura defect.
Can I ask DK, because this is something I learned from my neurosurgeons, that what I do is of course, as Samir mentioned, I don't I don't spread it on the defect, but I put a lot of layers of those tacker seal, Surgisil things, and then I put the tissue on. And what the neurosurgeons tell me is the tissue is just there to keep those structures there, just keep it there, and it's kind of like just to hold it there, like a suture, right, without putting in sutures, rather than actually using a tissue to cover it up.
If I might add there, I think the fibrin glue has a role as an adjuvant to what you do. Most times I've used is there has been a primary closure with the help of either a fascia or a muscle mass on top. And then probably to make myself comfortable, I've used the fibrin glue, not too sure whether it actually solves the problem. Whether your suture did the job or the muscle did the job, or the fibrin glue essentially. And like I would agree with you, Samir, no role for it to be directly put on and open during.
So again, my two bits in all the my very strong belief that this the CSF leak is through a small flap opening. It is never through a large opening. It is not even through a round opening. It is through a small flap. So even those patients, who come from outside, who have persisted with leak, those who have re-explored, once you clear everything and you look under the microscope, what I see is one flap. And every time there is a breath, it opens, CSF comes out, it shuts, opens CSF. And that flap includes that patch of TCL glue. So unless the TCL is totally sealing off everything, there is really no point. And TCL is not a magic glue. See, what I'm sorry to say, my orthopedic colleagues seem to think is if you have a dural tear, you can just do just pour TCL glue and all is forgiven. But that is not so. It is not as simple as that. That's all I want to say. Umesh, please go ahead.
Yeah. So that is the reason why I put those two questions. One is arachnoid intact. What is to be done, and what is the question? When to use fibrin glue? And as it has been rightly said by Dr. Jason also that fibrin glue is just a method to keep our graft or whatever repair we have done in place, and it actually is not supposed to be used on an entire surface. And one other indication, I think Dr. DK also can add. I'm going to show what we did. So that usually when the arachnoid is intact, if you can just layer a full layer of fibrin glue on an intact arachnoid, when there is no actual CSF leak, usually there is small CSF ooze. And those cases also, the fibrin glue actually does the job. So this is what we usually did. We took a muscle graft from an uncauterized area, from a fresh area lower down in the wound. And so that is, once that was done, we identified that small defect. So that was the small arachnoid opening, because the arachnoid was intact over the rest of the area. So we put that small muscle, mashed it thoroughly, and then we put that small muscle into that gap that was there and took a single stitch. And that itself took care of the entire CSF leak. Means after that, the active CSF leak that was there, it stopped. And then there was just an arachnoid intact. We can see the pulsations over the rest of the area. And then we just covered it with a fibrin glue. Just to be extra precautionary in these particular cases, we also layer a small area of gel foam, and we put a muscle patch, a blood patch intraoperatively, because that covers the entire area. And the chances of CSF leak in these cases, what we have observed, because usually in pediatric, when there was a lipomyelomenigoceal repair, when there is no dura also, we have used this technique and it has worked well. I think we can invite some comments from the panel.
Yeah. So now, because actually we are a little running close to the end of the time allocated to us. DK, if you have something like this and this is the sort of repair, then post-operatively, what could be your So no, I think I have a question before that. Use of drain panel, use of drain, yes or no, on how?
I personally use the drain post-operative because we should prevent the epidural hematoma. But after in the bedside, if there is a hematoma is not too much, then I release the pressure half, and then one day after operation, I remove the hemobag.
Right. Rohit, what about you? If you have a dural tear repaired or not, what is your drain protocol?
Sorry, are you talking about the wound drain or the lumbar subarachnoid drain?
No, wound drain.
Wound drain, yeah. So I think we'd follow Dr. Chin's recommendation. We would use it depending on the size of the wound and what kind of surgery we've done. If it's a large wound, again, we don't want hematoma. If it's a single level surgery, then maybe we could, not put in a drain depending on how much of bleeding there was at closure. But more often than not, we'd use a drain. We would not charge it, and we'd put a little note on it saying keep it on the bedside. So there is even no pressure gradient. Really,
so you use a gravity drain, not a suction drain.
Yeah. We wouldn't charge the bellow, so to say. We just keep it on that.
Gravity, we call it a gravity drain. Raghu, drain, yes, no, quickly?
Yeah. So I would agree with what the only thing I'll add is I normally always put my drains cephalad to the wound, not caudad. And that's inherent the way I look at it. Even if there was no inadvertent injury, and unfortunately there is one that you find on the second or third day post-op, it saves me most times by putting it cephalad.
And when would you remove the drain?
So I think if I would have a check dress at about 48 to 72 hours, and if the wound looks good, and I actually try to get them out. So, and just probably jumping the bag, I get them mobilized and done with. And if it tends to look no more bloodier, I kind of take the drain out. So 48 to 72 hours, 48 hours probably.
In these patients, in the ones where you got a dural injury.
Yeah, I'm talking about that. So I normally try to keep it not more than 72 hours, surely because of the risk of having infection. Indwelling drain for me sometimes actually is more worrisome with infection with such kind of a wound. So 72 hours, because there are times where you might find 300, 400 cc's even on the fifth day. How are you going to define that when to stop? So 72 hours, I would mobilize. And if they are good with no meningism signs, then I think 3 days is what I would keep it. Yeah.
So I tend to leave it slightly longer. See, my principle I do the same thing. I do a gravity drain. And if there is CSF coming out of the drain tube, I also tunnel the drain. I don't take it out straight. So I would tunnel it. I would take it out cephalad. And my principle is that if the primary wound heals, we can get the CSF leak to be contained. You may have a pseudomeningocele, but at least you won't have a CSF leak. And therefore, I keep it for 4 or 5 days. And then after it reduces, I then pull it out and I take a drain stitch so that there is no place for the CSF to escape. And at worst, you will get a pseudomeningocele, but the superficial layers would have healed. So that is my protocol. My next question is CSF. I mean, he's put it's actually Umesh's question, but I will take it from that. CSF drainage, that's subarachnoid catheter. Jason, would you put in a subarachnoid, what's called a lumbar drain?
No, I rarely do that in the initial stage. If there is complications afterwards, then yes. Symptomatology progress.
So not primarily. DK, do you put in a primary lumbar drain?
It is case by case. So if the dural defect can be controlled, so for example, if there is arachnoid membrane is intact, I do not insert the catheter. But the dural defect is so large, so in some case I do the catheter, lumbar catheter in the operation room. But in most cases, after operation in the ward, so if there is a CS in the wound, in the back wound, there is a CSF collection. At that time, I insert the catheter, CSF catheter.
Okay, Rohit, mobilization? Yes, no, which day? When would you mobilize these patients? This patient?
About the 4th or the 5th day, maybe the 5th day.
Okay. So, Umesh, what about you? When do you mobilize? I mean, you actually
So
have
we
this patient,
keep we keep the patient on rest till the drain is removed, because once with the drain and with the patient in an upright position, the drain is never going to stop, in the sense if we are looking for an endpoint for the drain removal. But as already been pointed out, sometimes these drains just keep pouring out, and as you pointed, we just wait for the skin to heal, and usually we also keep it for around 4 to 5 days. We remove the drain. There is already a cutaneous fistula around the drain tract. So we take a proper figure of 8 stitch around the drain tract so that the CSF doesn't ooze from the drain side. But otherwise, once the wound is completely healed,
do we believe that bed rest works? Bed rest or the reducing the CSF pressure works?
Except for the ones who got frank, little meningism signs or otherwise, no.
No. So what about, is there a difference? DK, may I ask you one thing? For the lumbar CSF leaks, we always keep the patient on bed rest or head load. What about the cervical leaks? Is there any point in keeping them in bed, or can they be made to sit up?
I bed rest.
Bed rest, yeah? You give them bed rest?
Yes.
Okay.
So until in the wound there is no CSF collection, or and after the removal of the lumbar drainage catheter.
Okay, fine. So now, because we have run out of time, so quickly, just a vote. Which of you? Let's go back. No, Umesh, go back.
Yeah.
Please. 2 other points, and we have to end after that. Diamox, acetazolamide. Yes or no? Rohit, yes, no?
No, I don't use it. We don't use it.
DK, acetazolamide?
I don't use.
Don't use. Jason?
No.
Umesh?
No, we don't use it.
So I think Raghu?
I used to, but now no.
Same here. I think it has no role. And antibiotics, I think that's going to be a very personal choice. I'm getting a lot of messages from the coordinators that we are run out of time. So I'm afraid I'm going to have to end here. And I'm going to have to summarize what we did. I think Umesh presented an extremely interesting case. It was that of an OLF, or ossification of the ligamentum flavum. We all learned as to how we have prevention strategies. We would use a high-speed drill. We would thin out everything. We would use a floating technique to float it rather than remove the entire thing. We would do a CT or an MRI to look for a double sign to see whether there is any intradural involvement with the OLF. And we can use an ultrasonic burr. Post-operatively, we have seen various repair techniques, and fascia seems to be the most popular one with a repair, and also the use of a tissile patch and or artificial dura in some cases. All of us are going to put a subfascial drain. We are going to keep it for a minimum of 48 hours till the CSF stops, but the drain is going to be on gravity. We do not use acetazolamide. We keep them on bed rest for 4 to 5 days, and we then mobilize them. And I'm afraid that's as much time as we have for this one. So, we have to respect the time part. I think we've learned a lot. I hope the panel agrees that in this 25 minutes, we learned a lot. And I would now ask the next case presenter, Arvind Kulkarni, to share his screen, and moderator Satyen Mehta to take over. And the panelists for this session being Manabu, Gabriel, Abhay, and Neeraj Gupta. And those who are not on the panel to switch off your mic and video.
Thank you, Dr. Dalvie. Dr. Kulkarni, can you start with your presentation?
Yeah. So can you see my slides?
Yes, we can. Go ahead.
So this is a straightforward case. I mean, this is a garden variety of case that we see every day in our practice. This lady came with a left-sided S1 dermatomal pain lasting for 3 months. The pain was getting worse with time. It was aggravating on walking, lying down. Probably it was there in all possible positions and situations. She couldn't walk for more than 2 minutes. She had recently developed numbness in her S1 dermatome on the same side. There's no bowel bladder movement. She had taken 2 root blocks. The first one had an effect. The second one didn't. And on examination, she had a positive SLR on the affected side. She had no objective loss of sensations, and motor power was normal. Rest of the neurological examination was normal. So we are talking about what happens later. So looking at the MRI, so she had a typically left-sided L5-S1 posterolateral herniated disc, which matched her symptoms and clinical signs. And we went ahead with the tubular discectomy. I was happy with the amount of fragment that was pulled out. And, after, we all do good surgery. So at the end of the surgery, I usually match the amount of disc with what is seen on the MRI, see to it that the nerve root is free and pulsating. And you spend another 5 minutes to explore all the corners, all the crevices to see that nothing is left behind. So she was happy for about 10 hours post-surgery. So next day morning at 4 a.m., she started complaining of severe pain. So Satyen, you want to take over?
Yeah, thanks. So I'd like to ask the question to Dr. Manabu Ito here. So this patient, sir, can you switch on your camera, please?
Yeah,
this patient. Yes,
yeah,
this patient has now was quite pain-free immediately post-operatively. She has a left-sided L5-S1 disc herniation. And the next day morning, she has woken up with severe pain again on the left side, left radicular pain, the same type of pain that she had. So at this stage, it's just one day later on. What would you be worried at this stage, and what would your plan of action be?
I think that there are several of the possibilities in the patient. Number one is hematoma, and number two is a recurrent herniation. These two the pathologies are very common in the early phase of the post-operative of herniated disc. Because the patient's pain totally gone, just immediately after surgery, and then almost maybe 10 hours and 12 hours later, her leg pain totally, much worse. I think that there's maybe the possibility is maybe hematoma and recurrence.
What do you think about neural handling? Do you think that could be a cause for pain, and that could cause pain the day later?
My personal experience, I don't know exactly about this, but maybe the pathology should be. It's most common is as I mentioned in the two pathologies as I mentioned.
Abhay,
thank you.
So Abhay, some kind of leg pain is expected post-surgery, right? Would you be shocked, if the patient complains of this kind of pain?
Yeah, Arvind, I get your point, but if she's predominantly talking of leg pain, more over back pain, I would, as you know, also, they are normally very happy with the leg pain. So in short, to answer your first question, it's not expected. I would not be comfortable with this, and I would communicate that to the relatives. Not that I would take action, but I would tell them that this is not normal to get this amount of leg pain after a well-done surgery. I would, in my, in a counseling session, talk to them through the steps of surgery, what we do, and tell them at what points things could have gone wrong. Tell them that this has not gone wrong. So convince them, or, share with them that my experience through the surgery was very convincing, and what is turned out right now is not okay. I would also tell them that we are not going to be able to discharge her till this pain goes away. And then I would discuss the aggression of investigations, because I would typically not want to investigate her on day 1 and day 2. But I would put that across, and there are some patients who are demanding of investigations. I would tell them the fallacies in doing early MRI scans and the reason why I would like to wait and give her medication.
Yeah,
thank you, Dr. Nene.
How much of pain would you expect? I mean, not everyone has 100% relief after a discectomy. This was sitting for 3 months. And is it expected, how much of pain is expectable pain after a discectomy?
I think if they're talking more of leg pain than back pain, that's not acceptable. Because they would be talking of some back pain, however small your incision. So that's all right. If they say back pain and thoda sa leg pain. But if they're predominantly talking of leg pain, it's not, in my mind at least, not acceptable. I may sell it to the patient in a different way, but in my mind, I'm going to be worried that night, when I go for a post-op round and she says my leg hurts, I'm going to sleep quite uncomfortably that night.
Dr. Manibu, do you expect some degree of leg pain post-op?
Yeah, some of the patients who have a severe herniated disc compressing the roots and the nerve is inflamed, and sometimes the patients have pain. But maybe I think that these pain will be controlled by the gabapentin and this type of medicine, not additional surgical treatment.
So, Neeraj, Satyen, go ahead.
Yeah, so wanted to ask a question, put this to Dr. Gabriel Liu. At this stage, do you have anything else extra to add? And the first part and the second part would be that what would you do next? Would you think about starting steroids here at this stage, or how would the treatment be? Dr. Liu, if you can switch on your camera.
Right, thank you. And then, I would agree with all the previous speakers talk about, and I'm glad that the distinction of the post-op pain is divided into the back pain per se versus the leg pain per se. And then, as you mentioned, back pain after surgery is expected, but severe back pain occur after surgery can also be due to instability of the facet destruction, license fracture, which is the common causes of the severe acute more back pain than usual. But certainly after the discectomy, leg pain should subside. And in many of the cases, if you do it right, I'm sure many of us have experienced the leg pain have disappeared completely after the surgery. But if the leg pain is like this case, is more severe than before or persistent, worse still, if there's weakness in the leg and then that is not there before, my management would be thinking about epidural hematoma straight away. And then from that, most of the time, if the patient is stable, then I would get an MRI. If the patient is rapidly deteriorating, there might be a surgical wound exploration that is on the table as well. Would I start steroid? Yes, I would probably start steroid to protect the nerve a little bit, but meanwhile get my investigation sorted out. Thank you.
So your steroid protocol would be to protect the nerve and not as a part of treatment?
Yeah, it's just the steroid experience really for metastatic spine experience rather than trauma experience. But it's ultimately the steroid experience probably to treat me rather than to treat the patient. But yes, I would give the steroid for about 3 days if there is any potential weakness, withdrawal, or anything like this.
We have talking about this hematoma. How true is how many times does a hematoma cause compression? How many times has anyone explored and seen that there is a hematoma sitting there and causing compression? It is just to relieve ourselves, or to tell the relatives that sometimes blood might collect there post-operatively and that may be causing pain. But how many times have you re-explored and seen a hematoma, and how many times in the literature has it been shown that hematoma causes this root pain? Anybody?
Dr. Gupta, Dr. Neeraj Gupta, if you're there.
Yeah, I totally agree with that, like what Dr. Abhay said. There is a lot of, whenever patient complains with on the day one severe pain is there is a lot of self-doubt is there, but the key is we should not panic. So yes, as you told that some amount of leg pain is there, not always, but some leg pain can be there after surgery. We should be anxious if the leg pain is much more, or is it the same pain, or it is more than the previous pain. Then we should be more anxious. Then on the day one, we can just communicate to the patient about what we have done, and we can do the conservative measures like positioning, like Fowler's position. We can give them some analgesics. And
this discussion was about hematoma.
Yes, sir. Hematoma. Regarding hematoma, as you said, sir. Yes, I have not seen like hematoma causing that much pain in my practice. Hematoma really, although we tell to the patient, but I don't think hematoma actually causes that much pain.
Yeah, is it more of a theoretical, a laundry list?
Yes, it's more of a theoretical, and moreover, I think just to we are making a place to like if you want to re-explore, we want to re-explore. We just usually tell the patient that it's a hematoma. We want to just remove the hematoma, and basically, idea is to re-explore the wound.
Abhay, how would you communicate with the patient?
So I think there are 3 or 4 things that I have to tell him. I have to tell him I'm unhappy with this pain. It worries me. I would go through the causes of the potential causes for the pain. Nerve root handling as the first cause. Of course, unless there's something wrong during my surgery, which in your case it wasn't. Nerve root handling, hematoma as the second cause. And then the 2 or 3 worrisome causes, one being, wrong level surgery, one being, of course, hematoma and blood clot and re-herniation of the disc. And I would give them a game plan in my head. I would tell them that in this situation, I've examined her in front of you. Her neurology is fine. So there's no need. There's no red flag out there, but the pain itself is a red flag. I would like to watch this. I'm going to see her twice tomorrow. And I'm going to start her on some basic medications with a presumptive diagnosis that this is either nerve handling or hematoma, which then would be steroid or gabapentin. And then tell her that if she's worsening on X day, now that's a little differential, but maybe day 2, day 3 or day 4, get an MRI scan done to confirm that there's nothing. Because if there is something, I'd like to address it during this admission and not wait. Gabriel, yes?
Hi. Correct me if I'm wrong. And that, as far as I can remember, the literature is suggested there's 2 types of hematoma. The post-op hematoma, which occurs probably about day 1 or all the way up to day 3, 4, or even a week. That might be a post-op hematoma. And then the other type of hematoma is spontaneous hematoma. Both of the hematoma, the progression of the nerve deterioration can be rapid. And both of the hematoma, I think the recommendation is early decompressions. That might be an old literature review, but that is how I seem to record it. Thank you.
Can I say something?
Yeah.
Yes, please go ahead.
Yeah, my experience in the herniated disc surgery, I had not so many, but maybe several. I had the hematoma and causing this kind of the rapid pain increase after surgery. Maybe I think that one of the causes is the decompression side, especially under microscope, and tube is a little bit small compared to the conventional. So that even though the tiny the blood coming to the side of area is a little bit in the space is very small. So maybe I think the pressure is going a little bit much easier to go high. So I don't know, because we don't have any measure to measure the pressure there. But my impression is that if you do a very small incision and a very wide excision of the disc, maybe there's some possibility, even though that the drain is not so bloody, but there's still some area that spinal canal area, maybe the pressure pretty high from the very small blood bleeding there.
Thank you.
If I may be able to add a little bit, if we are talking about what is the reason for the hematoma, apart from I'm sure Dr. Arvind have done a meticulous cauterization and fusion, but sometimes if you use a tubular retractor, when we do the closure, we usually put our stitch on the fascia area and take a little bit of the muscle. And that part, sometime underneath the muscle, they can still bleed a little bit after the surgery. And that can potentially, if you're so unlucky, you hit the one that is bloody, then it will start to bleed all over again. So most of my tubular discectomy or microdiscectomy, I take some time to cauterize everything. And then after closure, I just make sure that there's no more bleeding coming out, because you can't really stitch all the way to close all the dead space in a tubular discectomy. So that might be one of the reasons, and it might not be the epidural that is causing the bleeding. Thank you.
Yeah, very good points made, Dr. Liu. Since you're talking at this stage now, when would you intervene? Get an MRI or an X-ray done? At what stage? Would you wait for a few days for this to settle down, or would you be more aggressive?
I think in Singapore if there's a pain is worse than the day before, and if you have clearly most of us who have clearly think intraoperatively, we have done a good job, and then I would probably get an MRI. I definitely would get an MRI if there's weakness in the leg. So almost the same day.
Yeah. Dr. Manabu, I think you agree. Is there anything else?
Yeah, I agree. And but sometimes the patients have a postoperative, one day. If you see the MRI, everything is, that the blood is there, and it's sometimes very difficult to distinguish between that, the hematoma causing the neural deficits or without deficits. So sometimes if the patient has a severe pain, it's better to open up.
Go ahead, Arvind.
I give you 2 situations. So after the first dose of steroid, after another 5 to 6 hours, when you go back for rounds, there's one patient who has no relief at all, and there's another patient who has about 50% relief in leg pain. Would you handle them differently?
Dr. Manabu?
I don't use steroids for this kind of patients. So
You don't use.
I don't use.
Abhay?
Yes, if she's better with steroids, I would take the foot off the gas and of course not discharge her, but conservatively tell her that, look, if steroids have acted, it's probably some swelling in the nerve and we have to keep her under watchful observation. But currently my blood pressure has gone down and I'm not thinking of investigations or re-exploration.
Again, we can go ahead.
Yeah, so in this patient, there was no relief at all. But I disagree with the fact that the leg pain completely goes away post-operatively. In my experience, I've seen patients who have had leg pain post-operatively, but not as bad as before. And you give it some more time, by next day morning, it is kind of reduced a bit. And in the next evening, it's much better compared to mornings.
Yes.
That has been the temporal profile, my observation in quite a number of patients. So I don't think you should panic immediately, but if it is disproportionate to what it should be seen, then you should panic. So this pain doesn't go away. So what next? Neeraj?
Yeah. Arvind, go ahead with what was done, please.
Yeah, sure. So so she was in significant pain and I got an MRI done. So this is what it showed.
Yeah, Dr. Neeraj Gupta, can you just comment on this? Do you think that this is just a recurrence, or do you think that this is the scarring?
So for me, it looks like a scarring, sir. And I would I would not panic, and I would explain to the patient that since it's an early MRI, it's showing some changes. So we will just wait for some time. We'll try for. If there is no neurological deficit, only pain is there, we'll give some steroids, and I will try for blocks also in this case on third or fourth day, and see if the pain is subsiding. And if there is no neurological deficit, we'll try to continue on the conservative management, not immediately rush for the second surgery.
Dr. Nene, what do you think about the MRI?
So I agree with being conservative here. But I don't agree that you can have a scar on day 1 and day 2. Plus, a scar will need a contrast study. So this is definitely something there. But there's something called a ghost disc, which means that when you take a disc away, there's an empty space that's created and the MRI creates an artifact, the open annulus and a shadow. So I will have to counsel this patient that, look, at least it's not the wrong level. And at least what we see inside is not something drastically out of my hand. There is a possibility of going in again. But personally, I feel that since there's no deficit, this patient I would manage with medicines, and if not, then like Neeraj rightly said, blocks, and keep the word that I may want to re-explore in the pipeline when I discuss, because some of them jump to it and they say, why don't you do it right now? And sometimes this is the best time to re-explore, because in the heart of hearts, I know that there's a concern of a recurrent disc.
Yeah, is there yes, Dr. Manabu, please.
Yeah, and when I take a look at the left hand side, the sagittal plane, you can see the black line, and underneath the black line, you can see the disc material. And then I think if you would like to distinguish between the herniation or hematoma, maybe I think it's better for you to do a contrast MRI scan, so you can differentiate between the two. But when I take a look at this might be, for me, it looks like the herniation, the recurrence of the herniation. So because of such a profile.
Dr. Manabu, would you call this a recurrence, or would you call it an incomplete removal because it's just one day after surgery?
It's maybe the definition of recurrence, or maybe the lack of the resection. Mostly when you see from the surgical side with an endoscope, maybe you can cannot see anything. But I think that some remnant still remains in the disc space, because sometimes at the maybe young disc still there's some remnant sometimes left in the disc space. So always I wash it out several times to make sure no materials left after the discectomy. So maybe there is a chance because of the chunky disc material you removed, and then still some parts of remnant still remain there. So that's after surgery, patients move a little bit and then popped out to compress the nerve.
But Gabriel, what is your end point of primary surgery? When do you say that enough is enough? I don't want to waste any more time on this patient. When do you start closing your wound?
So I would see the lateral border of the nerve very clearly and then extend it all the way past the axilla. And then from then, that's my decompression extent. And then in terms of discectomy, obviously, as I did together with what you have done to match the MRI size of the disc to what you have removed. And after that, I will use my small little micropituitary and then to continue to take out all the loose fragment. The trouble with the disc is very old, and then there's a lot of loose fragment. I try to make my effort to take as many as I can, and then I will use what Dr. Manabu will still use the fluid to flush out everything. But if they still keep coming, then this is the problem one. So my end point is usually when there's a firm disc that I cannot pull out, then I will stop. And then if I really cannot, then sometimes I actually do something a little bit blasphemy. I actually burn the disc a little bit on the edge to make sure that there's no more loose fragment coming out, and also burn the nerve roots a little bit to reduce the pain at the back.
Well, Dr. Nene, any points, any thoughts on this? I mean, what about the washing of the disc and one point of that? And the second is, what is the end point of doing a discectomy here?
I think the few things that are under surveillance is, should we cut the annulus or should we not cut the annulus? So on that, my point is that I've read some anecdotal articles and I've talked to colleagues, and what I do is that if my 2 mm Penfield can go through the annulus, the defect, I try to not open it using anything and try to take the disc out from the same. If it cannot go through, then I often open the annulus. The next is that after removing the disc fragments, if I've got a couple of empty or a negative, when I pull out 2 times, there's nothing coming out, I normally tend to stop. I definitely don't like to do a disc wash because I feel that can potentially, cause discitis. That's a very anecdotal thought process. And I definitely make some room in the neural foramen, some bone work to accommodate for some additional disc prolapse. But I think with all these done, there's still a 15%, recurrence rate in a microdiscectomy, which we should accept.
So this is a practical question. All of your great travelers over the weekends for conferences, meetings, etc. You operate on Friday evening, and Saturday, Abhay, you have to go to Hong Kong for a 5-day AO meet. And this happens early morning on Saturday. I know.
Yeah, so I would hopefully take time out to counsel the patient. That's one of the times that I tell them, look, I'm going to be away for 5 days. Sometimes I don't tell them, but here I would tell her that I'm going to be gone now. And I put my next best man on board, and I share my telephone number with the sensible relative in the family to be in touch. Because I won't cancel my Hong Kong trip for this. This is not a post-op paraplegia, but I would do these things, yeah.
So you'll come back and you'll manage conservatively till you come back.
Yeah, likely. But in the recent times when I was traveling like crazy, I had my next best man re-explore also. I was in the picture, I was talking to them, but I was not present for the re-exploration, and it worked out well.
Yeah, I think in addition to this, one of the things that I find is useful is to actually talk to the patient first and then tell them the next day I'm going to be away. And then, do you want to do the surgery? If you don't want, I would not do the surgery. And then if things actually happen, not only informing the patient, but the family members, I think it's very important. And remember the reason why the patient want to sue you because they're angry with your management. So these are some of the things that I find is quite useful in my practice.
Go ahead, Arvind. What was done next?
So just before that, I'll ask one question. So how many of you would suggest primary fusion in a situation like this? You don't want that headache of early or late recurrence at all.
No primary fusion for me.
The reason I'm asking is when patients have shopped all around the town, there are some surgeons who suggest fusion. So it is very difficult to fight an argument, when such a situation is described to a patient. Such an option is described to a patient.
But I think there are enough reasons that we can tell them why not to fuse. You start talking about the disadvantages of fusion, the increase in complication rates with instrumentation, and the issue of ASD. and the fact that you're fusing a segment that nature had made mobile, I think that can easily sell them the concept of versus the 15% risk of recurrence. You see, so I would not. What do you do, Arvind? You've been quiet. What do you do?
Me? I'm going to ask questions and present this.
Arvind, go ahead. We don't have much time.
Yeah. So what is the diagnosis here? It's so recurrent disc. If you go by textbooks and literature, it says disc herniation at the same site after 6 months, which appears to be faulty. We need to have a consensus on this. We have had recurrent disc herniations within 6 months. This is quite early because patient had good pain relief. So this is something called as early recurrence. That is what I would call this. Now, I would not do a contrast here because there is no scar, as Abhay highlighted. So, it's a juicy disc which is brightening on T2. That is more than enough and responds with the pain. And so these are the options. How many would do a root block at this point? Or any kind of, non-surgical in the sense, root block or epidural option. How many of you would use them as your, weapons?
So I would give root block if the pain is not subsiding in the next 2 to 3 days and there is no neurological worsening. So I would try a root block.
Anybody else?
Yeah, I'm not averse to a root block either. If I've decided conservative, I'm happy to try a root block.
Yeah, Arvind, can you tell us what was done because we need to conclude this?
So this patient was in severe pain. I knew there was a fragment hanging out there. And I didn't want to beat around the bush. I did a discectomy again. So the patient can again ask you, can it happen again? So if it can happen once, it may never happen again. But if it can happen twice, it will keep happening. That's what Coelho says. Yeah, so this is the paper which is the only paper which talks of a early recurrent disc herniation. Thank you. So you can.
Thank you.
Satyen.
Thank you, Dr. Arvind. I think it was a very good case with good learning points about disc herniations, about the recurrence and how one would manage it. And I think an important point that we have learned is that that we need to counsel these patients very well and the family very well before we go on and operate on them. I'd like to hand over the proceedings to Dr. Dalvie to go on to the next case, please. Dr. Raghu, can you start your slideshow?
Hi, guys. I'm back. That is a very interesting and very important topic because it's something we get into every day. So the complications were such that those which are scary, those which are common. And now the third topic is one which is exceedingly, luckily uncommon, but exceedingly scary. I mean, it would be every surgeon's nightmare. It is paraparesis or paraplegia, that is neurological deficit following a deformity correction. And my case presenter is going to be Raghuprasad Verma. And my panelists for this are going to be Manabu Ito, Gabe Lu, Rohit Amritanand, and Arvind Kulkarni. Please keep yourself still in this panel. It's going to be run the same way. We both of us are going to run this and ask questions. But let's hand over to Raghu. Raghu, take it from here.
Yeah. So nothing can be catastrophic and nothing can be more devastating for a spine surgeon than neurodeficit. And the jitters are always there when you're looking at complex deformity correction. But it actually enamors you more if it happens in not so complex deformities. That's where I invite you to the journey I've had. So she was a 30-year-old female. She was a homemaker, but would assist her husband in some farming activity. She would keep having alternate day back pain for chronic back pain. She progressively noticed a spinal deformity, which has started disabling her over a 2-year period more. She did have access to some medical care in the second-tier cities, and somebody rightfully did a HLA-B27, diagnosed her as an ankylosing spondylitis. But what was she here with us for? 2 things. Inability to sleep supine. You can see there she needed about 4 pillows to stay upright. And the other one was deformity. Socially, it didn't matter because she was already married with 2 kids. So that was not so much of a concern, but it was there at the back of the mind. And when we examined her, there were no comorbidities, no spinal signs, no neural signs, no Bradabauer. Hips and neck were good, mind you. So the hips being good made her, do cross-legged sitting, squatting, which is important for her at that time. And the neck being good improved her gaze to an extent. it was not compromised, but it was strenuous on the neck as she would stay through over the day. And that's how she was clinically. So a classical AS picture with flexed knees, flexed ankle, kind of pseudo flexion in the hips with retroversion. The gaze, you can see how she strains all the way up, and that's how she was clinically. And that's how she was radiologically. So almost horizontal sacral slope there, lordosis more so at the lumbar spine, true global kyphosis. Kyphosis at the lumbar spine, true global kyphosis there. And to finish off with the investigations, we had the MR, the CT, which was incommensurate with the angst that you would see, and nothing remarkable in the axial sections at the relevant areas. At this point, if I can throw up it to Arvind, if I might, what else would you want in investigations? Anything that you want to add on to what I've already done?
Yeah, I think you've done fairly everything that is required here.
Okay, so since we agree on that, let's look at sagittal parameters, and I'll just try to pick a few of you all. Samir, in this specific case, I know there's so much of sagittal parameters to balance parameters to look at. What would be your 2 or 3 ones? A few academic ones and a few practical decision-making ones here?
I think it's very important to look at both the clinical photo and the X-rays in a position with her standing against a wall with her knees extended, because that will give you a true idea of the imbalance. And the chin-brow vertical angle is very, very important. You need to know how far away her C2 is from the plumb line, and that's what you need to be able to sort of get back. Some of the other parameters like slope, etc., I don't think have any value in this. This is a global fixed kyphotic deformity, which has to be dealt with accordingly.
So, Dr. Ito, Manabu, if there's anything that you would add in your practice?
I think that's fine. All the images and the posters I can see, and I would like to see to check the range of motion. Sometimes the patients have a hip contracture, but I think that the patient is young, so that maybe she doesn't have these kind of things. So that maybe only.
So she was good at the hip. She was good at the hip, so she was good. Okay. She wasn't too bad. Yeah.
Maybe all.
So So we did run a few of them. Arvind, you want to come in? You want to say something?
I was just wondering if you're planning in the direction of surgery. So one of the things you could wait for is, progression of her horizontal gaze, which she already has now. She's able to straight away. She has a horizontal gaze, and that should kind of push you a foot backwards with regards to plan for surgery.
An intervention. Fair enough. Her point was the inability to stand too long. Farming wasn't too difficult for her. She could crouch and do things. And she would get strained at the end of the day with the neck. The gaze wasn't a problem, like I said, but it was adding out to the strenuous nature of her. She couldn't, by the evening, she had enough of the day, that kind of scenario. Anyway, we did a few runs. We did the global kyphosis. That's how we did. The SVA, you could see at about 19.8 centimeters. It was a kyphosis, mind you, at 6.4. Did kind of mark out our pre-op, PI, the assistant PT. And like I was mentioned, from the C7 tilt, we did measure that. And we also at 72 and the spinal sacral slope at about 80. So we had a pre-op in place, and we decided, okay, go ahead, let's plan this as our plan. L3 PSO with bilateral D12, L1, L2, and L4, 5S1 pedicular fixations. Dr. Liu, would you have another plan here for this particular case?
No, actually, I would do similar things. And then one of the things I just want to add in terms of the parameters to look at, I will also look into not only the chin bar angle, and then I will look into the C2 center of head gravity line, C270 SVA and C7 SVA. By looking at the 3 SVA, you will determine the lesion is cervical or lumbar. And if these all 3 lines are anterior to the sacrum, this is a lumbar deformity, which you have diagnosed in here. If this is a lumbar deformity, the go-to I go to is that if we can get a whole EOS spine alignment, that would be good. Because as Samir was talking about, your knee is flexed. So whatever you get in this alignment is not the true alignment. You need to add more. So my go-to alignment in the lumbar is the pelvic instant. Still is the pelvic instant. Yes, you can be adjusters and all this thing. But looking at this pelvic incident, you're talking really almost about 60, 70. and then you need a huge lumbar lordosis. So in order to get the huge lumbar lordosis, I might go for L4 PSO rather than L3 PSO to get a bigger correction in the lumbar spine. Thank you.
Rohit, would you be any different? 3, 4, 2?
No, I just reiterate what Dr. Lu has just said, that I think the spinopelvic parameters are fairly critical because that's where the foundation of the whole thing is built on. So you have Sook's formula, which talks about the lumbar lordosis, thoracic kyphosis. And I'm not sure, do you use SurgiMap to do your planning?
Yeah, in that time, this was in 2017. I haven't used it that time, but nowadays we do.
Yeah, but anyway, the point being that the amount of osteotomy I do would be based upon my PI and lumbar lordosis mismatch.
Sure. So here we decided on 3. I agree that Rohit and Dr. Liu thought about 4. We did the 2D go.
If I may just interject here, I think we are maybe, we are getting a little carried away with this PI-LL mismatch in this case versus the standard case. In standard cases, you have mobile lumbar spines and you're fixing fixed lumbar segments to get back lumbar lordosis. In this case, it's a completely fused spine. It's like a bent rod, and you just want to do a compensatory osteotomy to get the head back. So I don't think those principles have any meaning whatsoever. SurgiMap would be ideal to do this, but I was doing these since 20 years, way before SurgiMap even came. And we did something even easier. We just bought a tracing paper and we traced it out and we actually cut it and we saw how much osteotomy at what level would get the head back. Because the main point is to get the head back on the pelvis as much as possible. Right? And it's a compensatory osteotomy. So we are not creating any lordosis. We are not creating anything. These are 2 fixed, rods of bone which we are getting back. At this point, as moderator, I must also interject and say we need to go to the topic, which is not deformity correction, but
so why? Because why this was being discussed? Because the 2 big reasons for complications is poor pre-op planning and poor execution. So we did everything that we could do at that time to look at it, and with all the things in place. Here, Samir, we are in the OT here now. The cardiac and pulmonary function test were looked at, bloods kept in place, and the exposure itself lost about 800 cc. And we had about D12 to S1 exposure. We had the screws at D12, L1, L2, and the L4, 5, S1 in place, largely uneventful, but except that the left D12 screw was put, there was a drop in SSCP. And this is how it looked. And we have documented evidence there where you can see the drop in SSCP. The amplitude had dropped to about 76%. Now to the faculty, Samir, if I can involve, drop in SSCP for a screw at D12, how much would you be worried and what would you do next?
I mean, obviously, the first and most important thing is I would do imaging. I mean, I would do very critical re-imaging to see whether my screw is really off or not. If I would ask them to repeat the thing, I would check everything, whether it's a false alarm or it's a real alarm. Is the relaxant okay? Is the blood pressure okay? And if everything is okay, and I would look at the imaging, and to me, the imaging is also okay, but still there is a drop in SSCP. I may even do a small laminotomy to see that my screw is not hitting the cord. But usually, especially at T12, the imaging is pretty clear unless the bone is so bad that you're not getting a good X-ray. But normally you would be able to see it. And if you're blessed to have something like an O-arm, I guess you can do an O-arm too. But that this would be my protocol. I would just
so Rohit, drop in SSCP at 76% worries you?
Yes, it does, because anything more than 50% worries me as long as it's commensurate with the MEPs. I also use triggered EMGs. So each screw that I put, especially if I have a slight doubt, I will use a triggered EMG to around 12, maybe around 12 millivolts is the threshold. So if there's a harmony between all 3, then probably I would consider doing all the things that Dr. Samir has said, or else also remove the screw and do a direct palpation and then upsize it by a little.
So that's what we did actually, and I agree with you that we did a triggered EMG and it looked good with no breach of pedicle. The screw physically was revisited and found to be good. Then we started our decompression. So we had the posterior elements off at the L3 and the proximal L2. We decancellated the vertebral body. Pedicular osteotomes were used to remove the pedicle. We used a wee bit of burr to decancellate. And we got temporary rods put both at the osteotomy sites above and below the osteotomy sites. That's what we had in place. Now, here's where the problem started, that we found the decancellation procedure a little difficult because the rods were in place. And at that stage, we actually took one-sided rod off, which is the left side rod off. The right was intact, mind you. And that's when we decided to start the posterior wall of the body getting impacted into the vertebral body at that moment. Our L punch slipped and hit the dural sac. Mind you, there was no dural breach, but the impact was significant. At the same time, despite having an opposite side right rod intact, there was a sudden collapse on the left side. Dr. Liu, at this stage, what happened was that we had a drop in the left-sided lower limb MEPs. Both tibialis anterior and abductor hallucis had gone off. Right, mind you, was intact. What would you do at this stage as a surgeon?
Right. Thank you very much. I just want to add one more thing in terms of my workup. My workup will include an osteoporotic bone scan. And then if it's severely osteoporotic, I probably won't do the surgery in the beginning. And then in regards to loss of neural monitoring, there's one good article published by Michael Vitale, which all of us in the world probably use. When the loss of IONM, the neural monitoring, they divide it into the patient factor, the anesthesia factors, the technical factor, as well as the surgeon factors. So obviously, you need to reverse all these things. So based on what his protocol is going to be in this situation straight away, we know there is a surgical problem because we hit the nerve. But we still have to optimize the rest of the thing. So, for example, make sure to do the due diligence, make sure the leads are all okay. The anesthesia, raise the MAP to 85. Most of the people will now go to 85 rather than anything lower than that if you're on a nerve deficit. And then and try to reverse and examine what is the last step that causes the problem. In this case, it's a direct trauma. Then there's no rod to remove, there's no screw to remove, no imaging. You just have to maybe in my practice, I would give steroid. I would give 8 milligram Dexa, and actually I would give 16 Dexa altogether. And if it is a young patient, I might even give high dose steroid. And then there are, yes, everybody is frowned about acute trauma or high dose methylprednisolone protocol. But I just came back from a CSRS American meeting, and then Michael Failings was talking about in a subset of patients, if you do it right, there might be some improvement. And then, of course, you don't do it in people who have recurrent bleeding, elderly infections, and things like that. In this 30-year-old young woman, you have nothing else to lose. You lose a lot of pressure, and then because this is still at L1, it's still at cord level. So I will go out to help the patient. Thank you.
So, Arvind, anything else you want to add at this stage?
Right.
So we did the recommended checklist. Yeah, Arvind, you were saying something. Sorry.
The same thing, MAP, steroids,
sure.
Guns out, blazing to rescue her.
Yeah. So we went the same way. We first thought about what we could reverse. There was no traction to be removed. There were no distraction forces there. I had a colleague of mine equally capable as a spine surgeon next to me. He said, why don't we put back that temporary rod in place? Because there was a big collapse at that segment. Can we do that? We did that for whatever reason. Like as we mentioned, we got the MAP up. It did fall to around 76 at some stage when we were actually decancellating. We got it up to 90. Normothermia was maintained. We kept the anesthetist in the loop. I asked the guy who was doing the neuromonitoring to check his electrodes, look at the patterns, signals, where there's corroborate evidence, and then go back and look, retrospect yourself, introspect. Decompression, was it adequate? Was the osteotomy sites leaving back some bone pieces? Is the laminectomy sites good? And started to think about probably a post-operative. We don't have a provision for doing an intra-op imaging, but post-op imaging was in my mind. Mind you, just on a funny note, a lot of things talked about is stop extraneous stimulus like music. My surgery is always with music, and the Indian classical continued. I didn't bother to revise that one. So what did we do? Transient stoppage of the surgical manipulation, irrigate it with warm saline, which we did. A lot of warm saline to take off the extracellular potassium. MAP was raised. Increasing body temperature was brought in. Methylprednisolone was just given about half an hour before when we had started to decancellate. So we didn't repeat it. We gave us Dexa at that time, and temporary rods were loosened. And we decided mutually that let's not reverse anything because there's nothing much to reverse because possibly the impact on the osteotomy was the cause. We started the close the osteotomy, resulting in the correction of the lordosis, which was achieved. And that time, additional drop in the lower limb on the right side happened. Fortunately, it recovered in about 5 minutes time. So we put back the rods in place. Multi-segmental fixation was done. But when the patient was extubated, grade 0 left lower limb, grade 3-4 right lower limb, 50% intact lower limb, sensations very dubious at that moment because she was just about coming out of anesthesia. We had lost about 1.8 liters, but well replenished. And at that stage, we had no time to even look at how well the correction had happened because as a surgeon, we were kind of devastated.
But how
Dr. Manabu Ito, at this stage, with that being the neuro, what would you be doing now?
I think that you did everything on the possible measures to recover the problems. So that I think that just wait for the recovery after surgery.
So this was the only image I had left with me. This was a Siam image at that time. Rohit, what at this stage? Imaging, when and what?
Raghu, before I go to this, I just wanted to check with you your L punch. When did it slip? I mean, do you keep a sliver of bone while you were doing the L punch, when you go underneath?
Yes.
Or was it just naked on the PLL and that's when it slipped? Because if you keep a sliver of bone, right?
There was a sliver of bone. I think it was inadvertently directed. I mean, this is retrospect 8 years ago. So I wouldn't know what it was, but there was a significant impact at that time. The first thing I was worried also was dural breach. Yeah. At this stage, Rohit?
Yeah, I'd get a CT. I mean, rather than get the X-ray, I'd probably have got a CT as soon as she recovered from, from anesthesia. The moment she was stable, I'd take her across to the CT, make sure that that I wasn't missing a screw breach anywhere, confirm that. And if that is how it is, and if there is no bony impingement into the spinal canal, then it's just probably iatrogenic, the slip of the osteotome as well as that sudden give that you had once you took out the temporary rod. Then she's on
MRI, Arvind, at this stage?
What about the hip? You said your osteotomy is at L3, right? What about the hip flexion and?
Yeah, so we did it. We did. I think I didn't mention it. We closed the table as we would do. Basically, we had kept the table in that flexion mode and then accommodated and got it done. That was done. That was part of the maneuver when we closed the osteotomy.
You said lower limb 0. How about the hips? Any movement in the hips?
Difficult to recollect at this time, but I know the knee and the ankle was 0 for sure. Yeah. Dr. Ito, sensation 50% intact, but difficult to assess. No, after long surgery, it was difficult to. Imaging CT for you at this stage, Dr. Ito, Manabu?
And for me, just because we had a direct trauma to the nerves, and then with maybe I think you checked all the decompression is done and the upper above and no hingement at the side of the osteotomy. If so, if the patient's recovery is not good, maybe we would like to check MRI to see the impingement and compression to the nerve.
So we did a CT, as Rohit did, and we looked at all these parameters, evaluated the decompression with no residue, laminectomy, osteotomy sites were looked at, implant positioning was reconfirmed, post-operative hematoma was negated out, displacement of the osteotomy site. Sometimes when you do that, there's a slide off and a slip off, which had not happened, and the CT looked all right.
If I may interject,
sorry,
Raghu. So I see. I'll just summarize this case. The way I looked at it, right? If you ask me, these sort of cases actually never land up with neurological deficit. It's at L2-3, and you've been candid enough to say that an instrument slipped and hit the cord, which is fair enough. We know what it is like. So now I'll say, number one, we know what the cause of the problem is. Number two, we did everything. We got the BP up. We did everything which we could do. Number three is that I would not be worried. I would be worried if I was the surgeon because I was there. But if I was a friend, I would not be worried because to my mind, all incomplete deficits tend to recover. So this is going to recover. I don't.
So you want to say that you wouldn't be imaging?
No. I'm not finished. I wouldn't be worried. I know this is going to recover.
Sure.
But at this point, we have two things to do. One of the things, of course, is to get the patient better, which is a prime aim. But the second is also medico-legal safety. And medico-legal safety means everything and anything can be questioned. So I don't think one should worry about whether an MRI is needed or not. You just do an MRI because nobody can fault you for doing an MRI. But I don't want somebody to come and later on say that why didn't you do an MRI? Because you always get one smart aleck to come and say you should have done an MRI. So the point is that you need to do anything and everything which is to be done, and you need it to be seen. There should be a flurry of activity around the patient. We're taking for CT, we're taking for MRI, we're doing this, we're doing that. The patient should not feel, though what to my mind, after this, the patient wakes up with a partial deficit, I just go and have a drink because this is going to recover. But that the patient shouldn't see that. The patient should think that you are really, running around doing this patient. So that's what I feel. So do everything.
Yeah. So we did a CT. We were anyway. We were anyway planning to do the MRI probably the next day. It was late in the evening. But as we were getting driven back home, we looked at Time for Literature. 2007 article talked about 11.1% with 2.8% having permanent deficit. This is always generally predominantly unilateral, never proximal to the osteotomy, which matched with what it was in our case, but did not get detected in neuromonitoring. We were kind of lucky that it got detected. Closer to now, 8.6, and the risk of 15.9% of unplanned reoperations required after a PSO. 30% was for neurological worsening, and mind you, most of it is for implant revision and reduction of the correction mechanism. With all this in mind, next day morning, our fellow calls up and says, grade 4 right lower limb, grade 1 left lower limb, and sensation status quo. Some hope there, like Samir said. So we started on aggressive rehab, hemodynamically kept them stable, blood transfusion to keep as much as replace that was required. And at 4th day post-op, we had these X-rays. Any comments, Arvind?
Yeah, looks good, but I have got away with a shorter segment fusion in such case osteotomy, just 2 levels above and 2 levels below.
Okay. So at 2 weeks was discharged with wound being healthy and mobilization with a walker and some human support with grade 2. And we kept the catheter in situ with antibiotic cover. Rohit, post-op rehab protocol for these people? Is there anything specific you're going to tell the physios?
Well, depends on what kind of motor grade she has in the lower limb.
Grade 2 lower limb left, grade 4 lower limb right.
Well, I mean, it'll be passives and then whatever active she has. And then...
How early would you get her out of bed?
As soon as pain, depending on pain tolerance, she'd be sitting by the side of the bed and then after that getting up with support. Her right lower limb is strong. She's got grade 4 power. So she'll have maybe a crutch. She's a young girl. So she may have a crutch with a cricket patch splint on one side and then she'll be up and out.
Okay, fair enough. So at 4 weeks, motor power was probably status quo, but subjective increase in sensation. At 8 weeks, left lower limb had gone to grade 4. She was catheter free at 6 weeks successfully. And at 3 months, nearly post-op back. This was a big phase of 6 weeks with running between assurance and reassurance, mind you. At 3 months, we got imaging. Probably kind of boost our, ego here and trying to look at everything being good. We managed to do a good correction, and also all those parameters were in good place. We got a minus 42 degrees there.
We are getting big messages that we need to wind up. So I just want to.
So I'm done.
Did she recover in the long run? To how much? Like what?
Yes. So she was back. She was back walking in 3.5 months. My last follow-up is now at 7 years. This was in 2017.
So is she normal now, or does she have a?
Yeah, she's normal. She's functionally back.
So she's completely normal. So that I think that underlines my. I think to me, my experience says that any deficit, which is a cord deficit, not a root deficit, although this of course was a L2-3, but any deficit which is incomplete always recovers. Any operative deficit. Because the incomplete ones recover. Then I'll be very surprised if incomplete ones don't recover. The complete ones you really need to worry. If there's a total deficit and if there's no recovery within a week or so, I would even say within 24 hours they don't recover. So just to wind this up, I think what important learning point I would ask first both our foreign faculties, that is Gabriel and then Manabu, if his answer is different. Gabriel, you are operating a patient and you are doing a surgery. Nothing has gone wrong. You are doing a standard check on your MEPs. And suddenly the MEP person tells you there's a 70-80% drop. Just tell me step by step what you're going to do. Just enumerate them because we are out of time. Just enumerate what you're going to do.
In short, I will follow the checklist as shown just now.
Okay. Could you, for those who weren't paying attention at that time, could you just enumerate it?
Okay, so the checklist is basically first thing check about the technical factors. The leads are okay. Secondly, the anesthetic factor, any abnormal agents being used. The MAP is go to 85 or more. And then the next thing is going to check on what is the patient factor. Is the HP low? If it's hypertensive, is oxygen saturation poor? Finally, is reverse whatever the last step you have done surgically. And then to look at if there's a direct trauma, yes, okay, there's a direct trauma. But if not, then whatever the last step you do, if it's a screw causes the drop of signal, putting in a rod reduction of the kyphosis causing loss of signal, you reverse that. And then check again after that. And finally, important is to get another senior surgeon to come in to prick the brain to share the burden.
Would anybody do a wake-up test? A wake-up and try to move the legs? Is that done today? Wake-up tests?
If it's 85% loss of signal, 75% loss of signal, you probably just wait until you see whether it's okay or not. If it's persistently not okay, yes, you can consider a wake-up test, but most of us probably won't do a wake-up test. Or in my practice.
Manabu, any final word on this checklist? Anything else you would like to add, or are we?
Just maybe for me, the technical points in terms and when you do a correction, maybe I think that this is the most critical and a point for the possibility to the neurological deficits. So basically, step by step destabilization. Don't do aggressive destabilization at the first at the one time, and gradually make sure that the spine is getting unstable. You have to put the rod as soon as you can to protect the spinal column. Once the spine is very unstable, it's very difficult to control. And if the patients have a very osteoporotic condition, it's very difficult to have stabilize the spine. So step by step, the destabilization, prepare the rod with the proper contour, the proper contour, and gradually correct the spine. That's the
right. So we conclude here with, I just want to give one learning point for the very juniors, that some people say remove the rods, but if you're doing a scoliosis correction, you may want to remove or reduce the thing. But when you're doing an osteotomy, you cannot remove the rods because the spine will be completely unstable. You can reduce the correction, but you have to keep the rods in. Right. Thank you very much, panel. I excuse you from this, and I hand over to the next session, which is post-operative disc space infection. And I hand it to the moderator, Satyen, and to Neeraj, who's going to present the case. And Satyen, please call your faculty.
Thank you, Dr. Dalvie. So I call Dr. Jason Cheung, Dr. D.K. Chin, Dr. Abhay Nene, and Dr. Umesh to please switch on your mics and cameras and be ready. Dr. Gupta, can you please go ahead and start your case?
Is my screen visible?
Yes, it is.
Yeah, thank you, Dr. Satyen. So, okay, I'm presenting a case. So, the patient is a 45-year female who presented to us with low back pain with left radiculopathy. She was bedridden for 1 week due to this pain. And when she was examined, her neurology on the left side, L5 was 3/5. Otherwise, her neurology was normal. Only on the left side, there was a deficit in L5. She had no medical comorbidities and her bowel bladder was normal, but she was in too much of pain. Because of that, she was bedridden of pain. We got the MRI done. This was the MRI picture. So we could see.
Yes, go ahead. What was done for this patient?
Yeah, these were the X-rays. Okay. So the treatment options were discussed with the patient regarding with the pain management and discectomy versus fusion. So we opted for microdiscectomy. Microdiscectomy was done. There was no intra-op complications. There was excellent pain relief on the day 1 after surgery. The patient was discharged the next day. 3 weeks later, patient again came to us with increased back pain. And there was mild left buttock pain. Initially, she had left leg pain. Now she had only mild left buttock pain, but instability. Previously, she was not having instability symptoms, but now there were instability symptoms was also there. There was difficulty in turning in bed. There was difficulty while she was moving, like getting up, getting down. There was pain. Back pain was there. and now the back pain was more hurting her, but the neurology was normal. So we consulted her, and she was managed conservatively for 2 weeks. We gave her some analgesics and asked for some rest, but no imaging was done at this time.
So I'll stop you there, Dr. Gupta. I'll want to ask this question to Dr. Jason Cheung about this at this stage. You've seen this patient now. She's come back 3 weeks later, and she now has increased back pain, buttock pain. She's unable to walk very well. All the instability symptoms. What are you thinking about at this stage, Dr. Jason?
Yeah, well, it's nice to know that all the symptoms have improved in terms of leg symptoms, and I suppose in your exam you have made sure that none of that has returned. So in that case, we're not really thinking about kind of a problem with the previous operation. But one of the things that might have happened is you need to assess whether it is a concern based on recurrent disc issues, a complication with the natural history of the disc being progressed into more degenerative processes, or is it really due to surgery, which in such a scenario where it's 3 weeks later, besides infection, which we'll be talking about, is of course making sure that there's no destabilization of the segment with, such as a pars defect or pars injury. So that would be kind of the thinking, that process going through when you're assessing these patients.
And how would you proceed then for this at this stage? Would you just continue with some more conservative management, or would you start thinking about ruling them out and getting the investigations done?
I probably won't be managing conservatively for 2 weeks. If 3 weeks of kind of no issue, and then suddenly there's having kind of recurrent pain, buttock pain, you're worried about these things. So definitely we'll do a proper physical examination, make sure you missed anything. But a simple imaging would be helpful. Looking at the X-ray features, the disc is very healthy, very thick and tall in your pre-op, so having any sort of subtle changes you probably see in the X-ray already. And as you said in the next slide, you did some blood tests as well to make sure there's no infection.
Yeah, Dr. Gupta, can you tell us what was done then?
So since the pain was increasing, so we admitted her and we got the blood test done. So her CRP was raised; it was 60. Her ESR was also raised, but other counts were normal. There were no other constitutional symptoms. There was no fever or any other constitutional symptoms. Wound was properly healed. Only instability pain was there with some signs of infections on blood. And we asked for MRI and CT. And this were the MRI images.
Yeah, I'll stop you there. Dr. D.K. Chin, Dr. Chin, any thoughts on the investigation? The patient's ESR and CRP are raised. And this is at about 4 weeks after the surgery. Do you expect this, and is this only in cases of infection?
Yes, I think in this case, after 1 month, CRP was elevated. So I think it is an infection case. So as for me, I also checked the WBC count.
Okay. Was that done, Dr. Gupta?
What, sir?
WBC count?
Yeah, it was all normal, sir. All other counts were...
And is that a concern if the WBC count is normal versus whether it is raised? Does that change your treatment or diagnosis?
So as for me, if even the WBC count is normal, the patient has a pain and CRP was elevated. So I think I will I will diagnose the post-op infection and I will treat them with antibiotics.
Okay. Thank you. I'd like to call Dr. Abhay Nene to get in at this stage. Dr. Nene, you're looking at this MRI. We know that it looks like a discitis, but can you tell us the features, whether could this be just a normal post-operative changes?
I think it can be normal, like all post-op MRIs show something. Of course, it depends on what kind of surgery I've done. If I've done a pure fragmentectomy, which means I've not even entered the disc space, and then the bone end plate still starts showing a discoloration, I would definitely be concerned. Also on the leftmost STIR image, you can see there's some anterior soft tissue that's playing up. And plus the, ESR, CRP are high, which again are not so uncommon after a surgery. But then clinically, if she's needed admission, so for me, clinical would be the topmost. And to cut a long story short, if she clinically is looking like an instability kind of pain with, possible infection, I would definitely put her on antibiotics and counsel her regarding biopsy, as well as versus empirical antibiotics, as well as resurgery.
Yeah, so since you've brought that point up about IV antibiotics, you have counseled them. Do you not insist on a biopsy?
I mean, the pros and cons of biopsy I put across, but again, this is a very anecdotal example. But in my experience, if the WBC counts are normal, I find it hard to believe that there is actually infection. And there's something called aseptic discitis, which is well known. And I may put this patient into that bracket. And I then sometimes tell them that, look, a biopsy is ideally indicated. But here, because your WBC counts are normal, personally, I feel without any literature evidence that this could be handled just with empirical antibiotics and wait and watch. But I give them a 6-week, outlier time frame.
Yeah, Dr. Jason, anything that you would like to add?
Well, just a thing that, previously, as I mentioned, I probably would have gone an X-ray first because normally it's not as easy for us to just get for an MRI and CT immediately because as Abhay mentioned, right, it's not septic, it's hard to convince a radiologist to give us an urgent scan. So with all those parameters in mind, it's also important to go back and reassess this whole case, why there would be an infection, right? So it's a MIS procedure. Infection is generally quite low risk anyway. Is this patient having high risk for infection? Do a whole body screening, assess for a possible source. It might not actually be in the spine. What you're checking the ESR CRP could be something else. So it's important to go back and really look at the big picture before jumping into starting antibiotics. And we have time. So if there is concern, although I don't think this is a contrast scan, right? We don't see a lot of edema around the disc vertebral junction. It's tough to even find a spot to actually get a biopsy. So probably we need a little bit more investigation and understand the big picture before going to further treatment.
About the big picture that you're talking about, are you looking for other foci of infection in the body? And if you do find something, do you investigate that foci first?
Yeah, I mean, you have to make sure if it's really from the spine or not, right? The back pain, it could be some, retrolisthesis you can see here, may not be actually related to discitis. So you need to be able to be sure whether the infection is caused by by this so-called post-operative, if the ESR CRP is actually caused by, and the back pain is caused by this discitis, or whether it's actually just a coincidence where you have a retrolisthesis leading to back pain, but you're also having an infective source somewhere else. So you need to just really do your due diligence and make sure you ruled everything out.
You mentioned about retrolisthesis. I'll ask Dr. Umesh if he's around. Dr. Umesh, you're seeing a little bit of retrolisthesis. Is that anything of a concern? We have a message from Dr. Srikanta as well about the retrolisthesis.
At this stage, I would not assign too much of an importance to retrolisthesis. But clinically, I think looking at the chronology of events, I would be more favoring and leaning towards post-operative spondylodiscitis. Patient has a new onset back pain, a new onset left buttock pain, which can be explained by the retrolisthesis, and instability signs are there. There is an erosion of the lower end plate of L5, which is unlikely in just a fragmentectomy. Again, there is a marrow edema that is showing up on STIR. There is a lot of edema around the operative site track that is there, which is again unlikely to be seen after 3 weeks. Patient has a rise CRP, ESR, as well as, total count. We don't know, but that is also all points towards an infective etiology, according to me. But the retrolisthesis per se, I wouldn't assign anything much at this stage. I think probably I would consider it as one of the factors when we decide regarding a definitive treatment for this particular case.
Thank you. Dr. Chin, Dr. Umesh talked about definitive treatment. Now, in this patient at your institution, how would you proceed? Would you get a biopsy done, or would you straight away start the patient on IV antibiotics?
So as for me, this is a post-operative infection case. So I will do antibiotic first.
Okay. And what is your protocol, sir?
What?
Your protocol, would you start with IV or oral antibiotics, and for how long?
I always check the patient's symptom and the CRP. So as for me, I will use IV antibiotics until CRP normalized.
And normally, how long would that take in your experience? Would it be around 2 weeks or 1 month or so?
So in my personal experience, it takes about 6 weeks after the infection diagnosis. So after 6 weeks, many patients, the CRP was normalized. But
so you'd
in some
continue
patients,
IV antibiotics.
Okay.
And what about biopsy? Is that something that you would do in these cases to get an organism?
Biopsy is in sometimes necessary, but if we start antibiotics and I closely check the CRP and patient symptom, if the CRP was decreasing and patient symptom was improved, so I think the antibiotic is proper. But if there was no response with initial antibiotics, then I will do the biopsy.
Thank you. Dr. Nene, what is your protocol on IV antibiotics in this kind of case? You said that the biopsy may not be very useful and you may not get an organism. So how would you proceed here?
Normally 3 weeks of broad spectrum intravenous and 3 weeks of broad spectrum oral. But I again do something controversial. I add an RC next to most of our patients. Apart from the clinical utility, I think there are 2 reasons why I would still back it with, despite people outside, raising their eyebrows. One is that India is endemic for tuberculosis, and any immune deficient area is likely to, to reactivate tuberculosis in your body. And the other is that it works as a sparsely used broad spectrum antibiotic, and it has very few side effects. So I normally cover them with that.
And if I would extend this question further, when would you consider a fusion, or would you consider it at all?
So I normally start talking about it from the first day when they have such bad pain, and again see the patient's response. There are some people who are very aggressive about their dates of recovery and they want their timeline managed. Then to fuse early makes sense. For a patient who's looking out for an early result, if you delay it, it becomes a messy affair. While there are others who are trying hard to escape any kind of a re-intervention, you just back them and support them because most of them come out of it well.
Okay, so it's very subjective and patient-based, and
Absolutely.
After a lot of counseling, yeah. Dr. Jason, in your practice, are there any pointers or any proper indications when you would go for a fusion versus just continue with IV antibiotics alone?
Well, I think in this case, we're assuming it's a discitis, then of course treat antibiotics first. And if the pain is unremitting and the infection is still not under control, after let's say a couple of weeks of antibiotics, then I would consider definitely the fusion. So we definitely would try just conservative care with medical treatment first. I do have a little bit different from the previous speakers in terms of treatment management kind of protocol. I will generally, for these cases, try to get biopsy if possible, because there's a lot of strange bugs we have here in our locality. And if we just start a broader spectrum antibiotics, most likely we can't get the correct specimen. And if in case we get infection that's not really under control that well, it becomes a bit of a nightmare to kind of figure out what to do. It's very easy to just get a biopsy, and it's very quick before you. And this patient is not septic, so you don't have to actually be that urgent to start IV antibiotics. Even for such a patient where there's no sepsis, oral antibiotics alone is good enough. Actually, there's a lot of broad spectrum antibiotics that have very good oral IV kind of coverage, so you don't actually need to give IV. especially in this patient who has had a previous MI surgery. There's no metallic implants inside. I'm not too concerned with just using oral antibiotics.
Thank you. Yes, Dr. Gupta.
Yeah, I just wanted to ask the panel what sort of IV and broad spectrum antibiotics. Dr. Abhay, can you tell what sort of broad spectrum IV antibiotics?
It's a bit institution based, Neeraj. Like the institution gives guidelines wherever the surgery is done, that which is the current broad spectrum that they prefer based on the last year's reports. Okay. So I mean, your guess is as good as mine.
Yeah, so we'll go ahead. So due to lack of time, I think Dr. Gupta, what was done there for this patient?
So we got this thing CT also done. The CT also showed that in the inferior end plate there were changes there on the L5 inferior end plate. We can even see in the body there were some changes. There were lytic areas were there because of infection, and all the treatment options were discussed with the patient regarding the conservative management and fusion, everything. So it was decided that the patient should be given 3 weeks of IV antibiotics. We gave meropenem along with oral linezolid. Patient refused for biopsy. There was mild improvement in pain with persistent instability and left buttock pain. And then we decided for fusion. Fusion was done, and IV antibiotics were continued for another 3 more weeks, followed by oral antibiotics for 3 weeks. And slowly patient improved. CRP was less than 10, and the fusion was done. TLIF was done.
Yeah, thank you, Dr. Gupta. And do you want to add anything, Umesh, to this?
Well, I would like to ask, so especially, in a case where there is no implants and where there is an active infection, and I know that TLIF is a definitive surgery, and most of these patients, especially post-infective instabilities, may require and end up in a fusion one way or another. But how aggressive should we be? I think it can go to the entire panel, like to put in an implant when there is an active infection. Especially when there is a good chance and where the patient is having good recovery from the infection. So how long should we wait before treating those instability signs after an infection? Because sometimes these may spontaneously heal and fuse.
Yeah, Dr. Chin, can you answer that question?
So in infection case, so after the cure the infection, there may be a chance of autofusion. So as for me, I will wait and IV antibiotics. But even though the long-term use of IV antibiotics, there is infection sign, I will do anterior lumbar interbody fusion with iliac bone without instrumentation.
Thank you, Dr. Chin. I think we can conclude this case here. We've got some very good learning points. That first of all, post-operative discitis infection is a real problem. It could be sometimes aseptic and versus a septic thing. As Dr. Jason Cheung gave some good pointers that you have to see the patient as a whole, and there may be other foci of infection which we need to treat pre-operatively to prevent the infections and also post-operatively so that we get the organism. IV antibiotics is the primary line of management. Biopsy, getting it done or not is a little controversial, but whether you want to do it, but IV antibiotics for sure we need to follow them up with blood investigations to see how they are improving, and if the patient continues to have instability pain, then we may have to go ahead and get a fusion done for these patients. So thank you to all the panelists, and I'll hand over to Dr. Dalvie for the next part of the session.
So this finishes the first part, or rather the larger part, which is the case discussion. And hopefully we've learned a bit more about these complications and other things. I remember when I was working with my teacher, and when any observer used to come and ask him, how do you deal with, for instance, if he's doing a transthoracic, how do you deal with an aortic injury if you're doing surgery? He said that I will make sure that I don't do the injury in the first place. And I think while we need to know how to deal with complications, and complications may be inevitable, we must try our hardest as surgeons to prevent complications. So I saw this talk by my friend Arvind on checklists and how they prevent complications. And checklists everywhere has been shown to improve outcomes and sort of reduce complications. And that's why I thought a fitting end to this webinar would be a talk on checklists. And Arvind, I will invite you to speak. The only thing is they are little running out of time, so the quicker you do, the better it is. And I call on Arvind to give his talk on checklists now. Arvind, your screen was shared, but it's unshared again. Yeah.
They're coming up in the old presentation. I stopped sharing that, but oh, I don't know why the old one is coming up. Can you see? So I should probably end that. Should I log in again to share this?
No, what is the problem, Arvind? If you share the screen, whatever you are playing on your screen,
no, the old
that
coming up.
It can only share what you are or what is on your screen. So you need to exit that presentation and open the new presentation on your screen.
I am doing that, but still.
So close the presentation, previous presentation.
Yeah, you must not be. Yeah, you just close your PowerPoint and open only that presentation because it is showing another screen. And as this guy pointed out, share your desktop. Don't share your PPT, PowerPoint. When it gives you the option, share the desktop.
Share your desktop.
Yeah.
Yeah, can you see the screen?
Yeah. Okay, go ahead.
Yeah, I thank Samir for inviting me to speak on this particular topic. So do we really need a checklist? Are we so dumb? At least me, I've done 17 years of training before I started my practice. And most of us have done the similar course. And so at the end of 16, 17 years, we are intelligent, we are wise, we are the upper crest of the society, we are the cream of the society. So we are, I assume we are made of superior stuff. So that is the very reason we get bored of mundane stuff. Things which look very simple and we take fundamentals for granted. They get ignored, they get neglected, the grassroots level stuff gets disregarded. So in such a situation, there is a potential for errors, and this is where checklist comes as a savior. It is like a knight on a with a shining armor coming on a horse, and it covers for our boredom, ignorance, absent-mindedness, forgetfulness, etc. If you see the organized world, the successful organized sectors in the world, they all run on a checklist. For example, this particular symposium, which was powered by Samir. So this is a dangerous slide. Every bullet in this particular slide is shameful, is underlined by shame. The temple, which we call the operation theater, happens to be the venue of majority of adverse events. Close to 50% of these adverse events are preventable. 1 million deaths per year across the world are a result of complications of surgeries. And it's shameful that 50% of these are preventable. I was going through this SSF yesterday. Lieberman is saying that about 1/3 of spinal surgery in the US fail, and look at the economical burden of this particular, happening. So why do complications occur? We are so well trained, so much of expertise we have. So is it failure of expertise, failure of expensive drugs? Is it failure of expensive devices, the robots, machines, navigation machines that we have? Not at all. They're all in their place. It is basically lack of integration, oversight, overconfidence, lack of communication. No, spine surgery needs integration. So it, taking this from the checklist manifesto, it is like an orchestra. To save one life, scores of people must perform 1,000 things correctly and simultaneously, right from the watchman at the door of your hospital to the MD of your hospital. So how did this, checklist generate in my mind? It was basically coincidental. So I started my practice in 2007. When you start swimming, that is when you learn. So if you take a graph, the maximum amount of learning that happens is in the first few days or first few weeks. There are a lot of gaps I saw in my practice. There are a lot of complications which I saw in my practice, which were because of some, things which are not ticked. So at the same time, I was reading this particular book by Atul Gawande, and I thought this particular checklist was not fulfilling the dimensions of a spine practice. However, basically, checklists will not teach you how to do surgery. Checklists do not teach you how to operate a complex case of scoliosis. Instead, they provide reminders of the most important and critical steps, the ones that even the highly skilled surgeons who routinely do such cases would miss. This is again paraphrasing from Atul Gawande's book. So we know, there is a WHO checklist which has shown, reduction in infection rate, reduction in mortality rate by almost 50% in developing countries. So why reinvent this particular wheel? It is not reinventing. It is basically giving a spinal spin on it, because spine surgery is totally a different arena altogether. You're overcrowded with thoughts when you are operating on a patient. It is a pinnacle of permutations and combinations. There are different regions. There are different junctions. There is again left and right. There are different kind of surgeries which need different kind of infrastructure, which are at a different layers. The difference between a good surgery and, bad surgery in spine practice, apart from surgical skills, is, different layers of infrastructure that we need in a practice. That is all well known. So that is how we divided this particular, we came out with this checklist with 3 components. So the WHO checklist, basically it is a clerking of the site, side, etc. But what is more important in cooking is, getting the ingredients right. You can't start cooking without your ingredients right. So pre-operative checklist is very, very important, especially when it comes to spine surgery. The patients have to have thousands of investigations done prior to surgery in terms of MRI, CT myelo if necessary, X-ray, nerve conduction study, etc. So all battles are first won in the mind, and we need implants. So all this has to be factored in before the patient is wheeled into the OT. So a pre-operative checklist is much more important than intraoperative, which basically is executional, checking the site, checking the name, golden hour of antibiotics, etc. And again, post-operative phase is very important. That is when complications get recognized. So that particular factor, that particular phase has to be taken into a factor when you are designing a checklist. So this is a slightly elaborate checklist, but spine needs such an elaborate checklist. It's a 37-point checklist. So these are 2 different group of fellows who studied adverse events and complications in year which was when the checklist was not used and when it was executed, and that too in a vigilant unit like mine. So we brought down the infection rate, complication rate, but quite a significant percentage. It does help. And, executing or incorporating a checklist in our practice is not something new, we are used to this. It is a routine practice to have a pre-anesthetic checklist. We have a checklist, just as Raghu mentioned, we rise on an occasion when there is a change in a signals by responding to it with the neuromonitoring checklist. So it is all well known. So why such a checklist suits our milieu, especially our country and the kind of society we stay in? Because there's a lot of stigma associated with spine surgery. We carry the infamous tag of failed back syndrome. The kind of complications that we see and face are irreversible and unpardonable. Patient getting paraplegic is just one example. And the cost I have seen in my practice, the cost of managing a complication is almost twice or thrice the cost of a primary surgery. So that is too much for a patient, many of whom still pay from their pocket in our country. And we, unlike other countries, have high volume of surgeries. We have untrained OT nurses and boys in some situations. The kind of resources that we have is limited and bizarre, especially if you can, for an example, is the neuromonitoring machines. which float in the city from one place to the other. We have floating inventory. We don't have inventory placed in a particular hospital. Most of us have a similar experience. Our fellows rotate, resident, and towards the end of their post, they are not interested. And there is a poor and disconnected surgeon and GP algorithm to rise to any kind of occasion. So this particular checklist won this S3P spine surgery safety in spine surgery project award. So this was a worded checklist then. Then we converted into a web-based checklist so that everyone in the team could interact. And the very next day, this web-based checklist got an award by the same institution, and it is published at various levels. So checklist is the application of knowledge we have consistently, correctly, and reliably. It is making things happen correctly. It shows that each problem has steps of solving, shows that each step is important, shows that the more you repeat it, the more you master it, allows surgeons to concentrate on non-mundane stuff, offers the possibility of verifications, establishes effective teamwork. There's a clear distribution of responsibilities, fosters effective usage of resources and skill, provides customer satisfaction. So to conclude, it is efficient, reliable, cost-effective. It's subspecialty specific to, subspecialty specific to spine. Most importantly, what I've seen is it stimulates discussion within the team. For example, I can tell you, there is a section for bailout option if a surgery fails. So the fellow reads about it. What is the bailout mechanism for a particular, for a particular step going wrong? So it reduces communication gap within the system. Again, there's no compulsion to use it. And, you can, again, customize this to your milieu, your environment, your hospital, etc. Thank you.
Thank you very much, Arvind. Thank you very much, Arvind. And this whole webinar is now over. I want to really thank our guests from overseas, from the AO Asia Pacific, who have joined us, spared valuable time. I'm sure their Sundays are extremely precious, and this is Sunday evening. They have spared their family time to join us. So Manabu-san, Manobo-incho, DK Chin, Jason, and Gabriel, they are all friends. They are all like, AO is like a very big family. So as such, I am not hesitant to call on them, though I appreciate their time which is given. The Indian faculty as well, all of you have risen to the occasion and come and join me. I'm not going to name you all. Thank you very much. And of course, the chairman, Abhay, who is our man right there at AO Asia Pacific. Vishal Kundanani and his team, who are the sort of torch bearers of this ASSICON, and they're really striving very hard to do a great show. And Dr. Srivastav and Badani. And I hand over to Vishal and Abhay to have a few final words before we end this webinar.
I think I can go first because I'm extremely thrilled with the way this webinar went, and I've been a part of most of the webinars of this ASSICON, and this one probably was the pinnacle because it was practical case discussions, and all the 4 AO faculty, brought out what AO actually stands for, and it's practical knowledge and information sharing at the same level. So everyone gave very undiluted and unfiltered views, which was a great learning experience. I'm getting some lovely, feedback on WhatsApp. Samir, congratulations that you conducted this so beautifully. And of course, the Indian faculty was, unparalleled. So I think I thank the ASSI for giving us this lovely opportunity, and thanks Samir for conducting this so beautifully. I think Vishal is not around. He's
Vishal
busy.
is not there. So then we will end this. Thank you all of you. We can all log out. And thank you for the technical team as well. Thank you. And have a great Sunday.
Thank you.
Thank you.
Recording stopped.